Hello, you're welcome to my platform. I am Dr. Sandra and I am a surgeon. I hope you become aware and sensitized about the different surgical conditions. Today's video is about a Meckle's diverticulum. A Meckle's diverticulum results from the abnormality in the formation of the umbilical cord, and it is usually as a result of the failure of the closure of a structure called the vitreointestinal duct. This abnormality usually occurs during fetal development when the unborn child is still in the uterus. In order for us to understand what happens in this condition, we have to understand how the umbilical cord is formed. Everything starts from the stage of fertilization, when the sperm fertilizes the egg in the ampulla of the fallopian tube. After fertilization, the fertilized egg has to transition to another stage called the stage of cleavage, where it undergoes cell division to form a cell mass called a blastomere, and it contains 8 cells. This usually happens around day 2 after fertilization. At around day 4, the blastomere has to transition to another stage called the morula. The morula is a result of cell division, continuous cell division, where the blastomere now has to continue dividing into other cells. The cells can multiply up to around 16 to 32 cells, and this entire cell mass is called a morula. Once in the uterine cavity, the morula has to go to another stage called the stage of blastulation. During this stage, the morula has to undergo several cell divisions to form a cell mass called a blastocyst. The blastocyst has 2 cell layers. It has the inner cell layer called the embryoblast and an outer cell layer called the trophoblast. At around day 7, the blastocyst has to transition to another stage. That is the stage of implantation, where it gets attached to the walls of the uterus, specifically the inner wall of the uterus called the endometrium. During the stage of implantation, the outer part of the blastocyst, that is the trophoblast, has to divide into 2 cell layers. That is, it has the outer part, the outer cell layer called the syncytial trophoblast and the innermost part called the cytotrophoblast. Now it is the syncytial trophoblast that digs deep into the endometrium, the walls of the uterus, the inner wall of the uterus, allowing attachment of the blastocyst onto the endometrium, that is the uterine wall. By day 12, the blastocyst has to transition to another stage, and that is the stage of bilaminar disc formation. During this stage, the inner cell mass of the blastocyst, that is the embryoblast, has to divide into 2 cell layers, that is the epiblast and the hypoblast. At day 14, these 2 cell layers, the epiblast and the hypoblast, grow in such a way that they form fluid-filled cavities above and below the midline of the blastocyst, respectively. The fluid-filled cavity formed by the epiblast is called the amnion, and the one formed by the hypoblast is called the yolk sac. By the 3rd week of gestation, when the unborn child is still in the uterus, the epiblast forms a layer of cells called the extraembryonic mesoderm. This layer of cells lines the inner lining of the trophoblast. The extraembryonic mesoderm will later form a connection between the embryoblast and the trophoblast, and this connection is called a body stalk. The body stalk is one of the components of the umbilical cord. At around the 3rd week of gestation, when the unborn child is still in the uterus, the embryoblast will transition to another stage. That is a stage called gastrulation. This means that it will have 3 cell layers instead of 2 cell layers. This process usually starts by formation of a structure called a primitive streak on the surface of the epiblast. After formation of the primitive streak, we shall have the first wave of movement of the cells of the epiblast through this primitive streak. And these cells will move in a way that they will enter deep into the embryo, displacing the hypoblast. and these cells form a cell layer called the endoderm. After the cell layer that formed the endoderm has migrated, we shall have another cell layer that will migrate from the epiblast through the primitive streak, and this will occupy the place between the endodermal cell layer and the remaining part of the epiblast, and this will form a cell layer called the mesoderm. And so the remaining part of the epiblast will form the cell layer called the ectoderm. So you can see that by the end of this process of gastrulation, we have three cell layers. We have the endoderm on the inside, we have the mesoderm in the middle, and then we have the ectoderm on the outside. So each of these cell layers will form the different parts of the body. For example, the endoderm is going to form the gut tube, which is going to be divided into the foregut, midgut, and then the hindgut. It majorly forms the gastrointestinal tract. It is also responsible for the formation of other organs, for example, the pancreas, the liver, and the gallbladder. Still at the 3rd week of gestation, when the unborn child is still in the uterus, the embryo is going to undergo folding in a craniocaudal fashion. That is, it will fold on this side where the head is supposed to be, and also this side where the buttocks should be. So it folds in that direction on both sides. And this also causes folding of the endoderm, the inner cell layer. That inner cell layer that was initially formed, that was first formed in the gastrulation phase, is going to also be folded into a gut tube. And this gut tube has three segments. It has a foregut, a midgut, and a hindgut. While the endoderm is being folded into a gut tube, the yolk sac will as well be folded, and it will also form part of the gut tube. And part of the yolk sac will be left connected to the midgut of the gut tube that has been formed. The connection left between the gut tube, that is the midgut, and the yolk sac is called the vitreointestinal duct. The vitreointestinal duct is the second structure that forms the umbilical cord. Still at the 3rd week, at the hindgut part of the gut tube grows a pocket, an outpouching, and this grows into a structure called the allantois or the allantoic duct. The allantois or the allantoic duct is a structure that drains the urinary bladder. The allantoic duct or the allantois is the 3rd structure that forms the umbilical cord. So you can see that we have formed the 3 structures that form the umbilical cord. These 3 structures that we have so far formed, that is the body stalk, the allantois or the allantoic duct, and the vitreointestinal duct, together with the 2 umbilical arteries and 1 large umbilical vein, form the entire structure of the umbilical cord. At the 4th week of gestation, when the unborn child is still in the uterus, the amnion also undergoes folding. Remember that the amnion was formed by the cells of the epiblast. The cells of the epiblast grew and formed a fluid-filled cavity. So it is now this fluid-filled cavity that was formed by the epiblast, the amnion, that now grows downwards to envelope the rest of the embryoblast. The folding of the amnion kind of brings all the structures of the umbilical cord together, and it also forms the outer lining that covers all the structures together, that is the body stalk, the allantois, the vitreointestinal duct. So at the end of the day, we have a fully formed umbilical cord. And by the 7th week of gestation, when the unborn child is still in the uterus, these 3 structures, that is the allantois, the body stalk, and the vitreointestinal duct, are going to emerge through the abdominal wall of the fetus, and they are going to emerge through a small opening called the umbilical ring, as the structures composing the umbilical cord. The other structures that will also compose the umbilical cord will include one large umbilical vein and two umbilical arteries. At the end of week 7, there is a disappearance or a shrinkage of the vitreointestinal duct and the yolk sac. Failure of the closure or the shrinkage or the disappearance of the vitreointestinal duct or the yolk sac can result into certain conditions. For example, the congenital intestinal fistulas, the umbilical adenomas, the Meckle's diverticulum, the intra-abdominal cysts, and the congenital burns. At around the 8th week of gestation, when the unborn child is still in the uterus, the allantois or the allantoic duct is also meant to close off, disappear, and shrink. And this leaves behind a remnant called the urachus. If the closure does not happen, we can end up with a patent urachus, meaning it is going to be left open. And this can result into certain conditions. For example, the urachal-fistulas, the urachal-sinuses, the urachal-cysts, and the urachal-diverticulum. In a setting where the vitreointestinal duct remained open, closer to the ileum, that is the last part of the small intestine, we shall end up with a small pocket, a bulge and outpouching in the walls of the ileum, that is the last part of the small intestine, a condition called the Meckle's diverticulum. The Meckle's diverticulum can either exist in isolation, that is alone, or it can occur in conjunction with the band connecting it to the umbilicus. This band that connects the Meckle's diverticulum to the umbilicus can also be responsible for the complications that we see in these patients. The Meckle's diverticulum occurs in only 2% of the population. It is usually located about 2 feet from the lower end of the small intestine. The Meckle's diverticulum can also have 2 types of ectopic tissues, for example, the gastric tissues and the pancreatic tissues. Ectopic tissues simply means that we tend to have tissues that belong to other parts of the body existing in areas they shouldn't exist. In our context, we expect to have tissues of the small intestine occurring in the Meckle's diverticulum, but we tend to have tissues of the stomach and tissues of the pancreas, and this is responsible for some of the symptoms and complications that we see in these patients. Although these complications can occur in only 2% of the people that have the Meckle's diverticulum. These complications commonly occur in children below 2 years. The symptoms are 2 times more in males than females. The complications and symptoms include gastrointestinal bleeding, which is usually painless. And this is usually as a result of bleeding from the Meckle's diverticulum. In fact, 50% of the cases of bleeding from the rectum in children less than 2 years is usually as a result of Meckle's diverticulum. So it is very, very important that we are always vigilant, especially for the health workers, to always be suspicious of Meckle's diverticulum in all patients that are less than 2 years of age that are presenting with dark colored stools or dark red stools. The other complication is diverticulitis. Diverticulitis is the inflammation, that is irritation, of the Meckle's diverticulum. If a patient that has a Meckle's diverticulum presents with diverticulitis, they will have pain around the umbilical region. And also when you touch the umbilical region, there will be pain emanating from that area. The patient can also present with abdominal distension, that is abdominal swelling. The other complication can be intestinal obstruction, that is failure of food and fluids to pass through the intestines well, such that they are excreted or eliminated via the anus, the anal region. Intestinal obstruction will present as failure to pass stool, failure to pass flatus, vomiting, and abdominal distension. So it is very, very important that you look out for the presentations or the symptoms of the complications. The investigations that we use to to diagnose patients for Meckle's diverticulum include a Meckle scan. This looks out for the presence of stomach tissues, gastric tissues in the small intestine. We can also carry out another imaging modality called the mesenteric arteriography. The mesenteric arteriography studies the large blood vessel, that is the superior mesenteric artery, that supplies the small intestine, and it usually looks out for the abnormal branch supplying the Meckle's diverticulum. Usually it should look a certain way without any abnormal branches, but when there is an abnormal branch coming out of it, we might become suspicious of a Meckle's diverticulum being supplied by this abnormal branch. We can also carry out an upper GIT endoscopy, where we put a camera through the patient's mouth and then we look at the small intestines to see if they have any outpouching, a pocket, a Meckle's diverticulum. When it comes to the treatment of the Meckle's diverticulum, we don't do anything for patients that don't have symptoms and complications. However, surgery is done for those patients with complications and symptoms, as well as those that have exhibited presence of gastric tissue, that is stomach tissue, in the Meckle's diverticulum, probably maybe from a Meckle's scan. So those patients, we always do surgery because we want to reduce the chances of complications like bleeding, ulcer formation in the future. So what we do is a surgery called resection and anastomosis. Resection simply means that we cut away the portion of the small intestine that has the Meckle's diverticulum, and then we can do anastomosis. Anastomosis means that we suture the two segments of the small intestines that were left behind, such that the gap that was left as a result of cutting away the portion with the Meckle's diverticulum is bridged. So the take-home message is, please be on the lookout for the complications of the Meckle's diverticulum, as these can be life-threatening. For example, look out for abdominal pain, especially pain emanating from the umbilical region. This can signify that the patient has a complication called diverticulitis. Please also look out for failure to pass stool, failure to pass flatus, abdominal distension, vomiting, as this can signify that the patient has intestinal obstruction. Please also look out for passing of the dark black stools or dark red stools, as this can signify that the patient might be having gastrointestinal bleeding from the Meckle's diverticulum. All these complications are life-threatening and they warrant urgent surgical intervention. So when you see those complications or those presentations, please bring the patient to the hospital such that they can get investigated and a surgery can be done.
Yes, that is what I had for you. Thank you so much for listening to me. Please share my videos and also subscribe. See you in my next video.